Hi, my name is Raya Marielle Han, and I'm here to present the assessment and management of pain in the elderly. The patient that I have chosen in our ward is Mr. G. He is an 81-year-old male who was transferred to us for continuing rehabilitation after his revision of his left total hip replacement. He's presented to us 8 days post-op with still ongoing bilateral leg pain both on rest and movement. He has been immobile for the last 8 days. He has an unstageable pressure area on his left heel and a friction burn on his right upper thigh. He's also been identified as one of the patients that has suffered delirium post-op. In any clinical setting, accurate assessment of pain is critical for the identification of appropriate intervention and for evaluating the effectiveness of these interventions. So for us to be able to do that, I have performed a comprehensive assessment of Mr. G. I have used different approaches to identify his own version of PQRST in relation to his pain. I have started my assessment by gathering all his health history, social, and family history. I have done a physical examination, to be more specific, a proper skin assessment, due to the fact that he just had a surgery done and all the present injuries that he had. I have also reviewed his laboratory and diagnostic tests that came with him from the other hospital. And because he's been flagged as a cognitively impaired person, we have also performed a cognitive and functional assessment. As we all know, pain assessment in elderly people with cognitive impairment is very challenging. Hence the reason I have followed two statements from both authors that I have cited on my PowerPoint. That is, pain may be assessed with behavioral measures and or self-report, and also self-report of pain is deemed as gold standard. Hence the reason why I have used visual analog scale and pain assessment in advanced dementia as my assessment tool. I have also gathered data from his family, which are considered his carers at home. During our first nurse-patient interaction, he was quite wide awake, slightly disheveled in his bed, and has a grimace face. He appears to be quite frail, moderate build, and has poor skin turgor. He had dressings on his legs and on his heels, and also both on his right and left hip. He's heavily deconditioned due to prolonged immobilization since the fall that he had at home and after surgery. During our interaction, his mood was quite low in nature and he had difficulty to follow simple instructions. From his previous notes, I found out that he had his first left total hip replacement done in December 2015, which was an elective case, and he had his revision done in March 2021 due to a mechanical fall at home with a long-term lie. He was actually discovered by his daughters 2 days after he had the fall. In his surgery, they used general anesthetic, and post-operatively, they've used oxycodone 2.5 to 5 milligrams every 6 hours for analgesics. He also had history of chronic back pain. He had an extensive past health history. He had hypertension, type 2 diabetes, which is insulin controlled. He had GORD, CKD stage 4, antithrombin deficiency, so he was on warfarin for the last 20 years. He has CCF, IHD, and his most recent ones are bilateral lower limb edema, rhabdomyolysis, and bilateral lower limb non-occlusive DVT. After speaking to his family, I've discovered that Mr. G is retired and lives alone in a high-set home. He has two daughters who comes home and helps him with daily needs. He refuses to get services, and the family has signed a consent for placement in a residential aged care facility. After history taking, I've proceeded to perform a physical examination. I've started off with taking his observations, which are all unremarkable. His blood sugar was 7.6. I have then proceeded to perform a skin inspection. I have noted that there is no bruising or bumps from his head up to his upper torso. However, there is some slight bruising on his right and left arm. Apart from his wound site, his major injuries were the following. He has a friction burn measured 5 centimeters wide on his right upper thigh. The site was red and inflamed with noted pus but no odor. He has a left heel unstageable pressure injury, which was measured 2 centimeters wide, open but no ooze. Eschar is present. His left posterior hip has the wound site, which noted to have 30 stitches. The site has slightly pink and red in color, no discharges. We noted that he was moaning when we rolled him. He had bilateral leg compression bandages, and when we opened it, it had lower limb weeping edema. We've noted that there is multiple skin tears on both of his legs. All of these dressings have been changed. We've also checked his backside and there is no further pressure injuries. Upon assessment, I have checked his other diagnostic tests performed at the other hospital. He had a few, but these are the ones that were standing out so far. He had ultrasound of his bilateral legs, which shows non-occlusive deep venous thrombosis present bilaterally in the gastrocnemius. His full blood count shows hemoglobin of 82. His leukocytes were 20.5. His CRP was 15 and his INR was 1.9. During my interview with his family, his daughters has stated that he has recent personality and behavioral changes. And also, before his fall, he was able to do personal cares. However, since the operation, he has been quite immobile and full cares were done by the nurses. Hence the reason we perform a cognitive and functional assessment. I've chosen the mini mental state examination, which is used globally to assess cognitive status in acute care setting, and the patient has scored 20 out of 30. I've also done an ACE-3, which is useful in detection of cognitive impairment and detection of Alzheimer's disease. The patient scored 80. After performing all those assessments, I have a better picture now on how to effectively assess Mr. G's pain. So I asked Mr. G, "Are you in pain, Mr. G? Are you uncomfortable?" And the patient says, "Yes, I am." I have then provided him a visual analog scale, which is one of the most common scales we use to assess a person's pain, and he's pointed it out. He is in very severe pain. He changed his mind again and he's pointed out he's in the worst pain possible. However, because of previous reports that he is constantly complaining of pain, even after giving him a tremendous amount of analgesia, I still have to provide another type of pain assessment. I have then proceeded to perform a pain assessment in Advanced Dementia Scale or PAINAD, which we commonly use with patients that are cognitively impaired. So I have observed Mr. G 5 minutes before our interaction while he was just lying in bed. And also I have observed his behavior while we were trying to move him up the bed for him to have breakfast. His PAINAD score in total was 8. Well, by now we all know that Mr. G is in pain. However, the problem is we are not aware of the intensity and the actual location of his pain. So I have the interpretation of the data that I've gathered. From his diagnostic tests, we know that he has been immobile, he has low INR and antithrombin deficiency. He was diagnosed with bilateral leg DVT. It has caused swelling and a possible cause of his pain. It showed also he has high leukocytes and high CRP, which may be an indicative of infection and swelling. Upon skin inspection, there was a presence of a wound site, a burn, pressure sores, and multiple skin tears, which will be a possible cause of pain. And before I go any further with his pain scale, his cognitive assessment does indicate cognitive impairment. His MMSE and ACE3 suggests he has dementia. Hence the reason I have not used his visual analog scale. He had changed his mind during the process, and in previous reports, he has been complaining in pain even before and after having pain relief. So I have opted to choose a pain ad score, which he scored 8. And as per Warston et al., it means 7 to 10, he is in severe pain. We have then provided Mr. G his endone 5 milligrams for his PRN analgesia. All his wound sites and pressure injuries clean and redress according to the wound care chart. And as per doctor's order, we have started him on oral antibiotics. Apart from that, we have opted a non-pharmacological management as well. We have provided an ice pack on his wound site. Upon evaluation, I have observed that patient is more calm and he has participated in morning cares, and there has been no reports of pain. And that concludes my presentation. Thank you.